可以吗？你问他还好吗？现在几秒了？70秒。It's now about 75 seconds. So we are now in the halfway. The temperature now is over 100 degrees.现在看得到吗？他们可以哈，好。那给他可以对一下那个针的位置吗？
Does patient complain anything?
She's doing well. She's okay. Yeah. But maybe because of a little bit sedation, she's a little bit sleepy now. She fall asleep now.可以看得到哈。OK。所以这个位置那个 power 好像还好哈。还好，
两位是那个目前这块绿色度可以稍微调一点。这边因为挡到。
挡到什么？哦。就先 scan 一次，对。Yeah. Scan. We will scan these patients after the first session. It is completed now. Okay, move the table inward. 来，把 table 先移进去哦。先动 table。保护好那个 cable, protect the cable. Okay, we are going to take the follow-up scan. 对。So, did we switch to the monitor now? Switch to the monitor now? This one? Yes. Okay, thank you.针有点跑掉，还好，他吸不太起来。Probably she is fall asleep and did not take a full inspiration now. No, lower, 这是往下哈，所以他现在吸气吸不起来。Upper. Lower. Okay, 我们再烧一次。I think we probably will give her another session.
So it seems that the lung volume would decrease during the ablation of the modality. So how do Dr. Kanagawa recommend to monitor during the ablation? Do we monitor during the ablation?
2、3、4、5、6、7、
We
8、
are
9。
always noticing about the glandulous appearance around the tumor during the procedure, and you can see the complete glandulous appearance around the tumor. Maybe on the image, the procedure is successful.
Yeah, 好，再回来，看他们，Okay. For complete safe, we will give another sessions to ensure the safety margin and the successful of this procedure.
And what route do you adopt next additional session at the additional session?
Because suppose that just one session is enough to cover the tumor, and we can see the ground glass opacity around the lesion.
I see.
But I think I would like to do a second session, another 3 minutes, to ensure the successful of tumor operation.
I see.
That's I see. Okay, we start now.
Do you adopt the same power?
Yes. Yes. 好，等一下。你先看它泡了。
正常的正常，这个是泡的。
对。I think you can see from the monitor. That's the data show. So I think the temperature is acceptable, and the treatment is continuing.
Okay. Are there any questions from the audience about the procedure?
Yeah. Yes, please. So, do you think that come to the flow line to cause pain? So, right.
So the question is, patient feels a pain as the pleura during the procedure. That's she?
对。我其实在下一张啊，下一张，应该就是上一张，差不多了，就差不多上一张。Yeah.
She's.
你帮他量一下1公分左右。
Professor Jiang is adjusting the needle and just have a scan and see the location of the antenna to see if there is a good coverage of the tumor.
Yeah, 左右各1公分。
Yeah. He's measuring if there is 1 centimeter around the needle. So he's drawing 1 centimeter.
Okay. Yeah. Maybe, yeah, up. Okay. Good. Do you want to switch to another case? Yeah.
还没有，不过他已经有局部已经有碳化掉。
I have one question that if there is no obvious ground glass opacity around the antenna electrode, what would we do next? Do we continuously wait until there is one, or what is the strategy?
We will give a second scan because we just finished the second session. So let's look if there is any more ground glass opacity. Okay, 再进去 scan 一次。Let's move the table inward and give another scan.
Professor Kanagawa. I think we just waiting for the scan for the second CT scan follow-up. So maybe we can change it to the second room for the liver operation. Okay. So if we have a further discussion, we can discuss later. Okay. Thank you. Thank you. Thank you.
这个线可以拿走，我拿了。
最高的地方，
做得到吗？我拿都可以。好，你拿好，靠近它就好了。
好，再回来。好，我再把针再上一张。
可以说了吗？
现在是
绿色应该就可以了吧？可以说了。可以了哈。Can you hear me, all the audience?
Okay.
Okay.
Yeah.
This is a case with a recurrent HCC about 2 centimeter in the segment 8, just below the diaphragm. It's very, very difficult to see the index tumor under plain ultrasound, and it's very dangerous to ablate the tumor without creation of artificial effusion and ascites. First, we create artificial effusion by injection of 500 milliliter dextrose water, and you can see the ultrasound monitor. We create the effusion successfully, and then we want to create artificial ascites, but it's very, very difficult to create adequate ascites because of the previous operation and the adhesion between liver and the peritoneum. But with the assistance of the effusion, see the index tumor more clearly. And we want to insert three electrodes with a non-touch technique to encircle the tumor without touching the tumor itself, to create at least 1 centimeter safety margin to ensure complete ablation.
Okay, yeah.
This is an index tumor, and very, very close to the diaphragm. And we infused artificial effusion to have a better visualization and to protect the lung. And we want to insert 3 needles, the first one, second, and third, to encircle this region to have an adequate safety margin without touching the tumor itself. Can you understand?
I think so, yeah.
Okay, it's all checked. Okay.
Okay, before opening for discussion, I have one question to the operator. So I understand by using the bipolar needle, actually we don't need the artificial ascites or effusion to protect the thermal injury, because I see the bipolar needle, for example, in this in earlier section, the doctor from Japan showed no need of no concern of gallbladder injury. Even the tumor is very close to the gallbladder. So in this case, I think it's still little far away from the diagram. So why in this case we need the artificial effusion?
Okay. Actually, on the CT scan, this index tumor is close to the diaphragm, very, very, very close. And we have a very, very poor echo window. So we should inject artificial effusion to have a better visualization of the index tumor. And the bipolar electrode can have in the outside the electrode. So injury to other organ is still a concern. So we should try our best to reduce the risk of complication. So please keep in mind, we can ablate the tumor in the inter-electrode space, and we can ablate outside the electrode. So it's always our concern for injury to other organ.
Could you please show the CT scan to audience?
Yes.
CT scan. 哎，那个现场没有影像，没有影像哦。
好，马上来。
Please show the CD scan first. Okay. Can you show the CD scan first? Hey, what do you mean? 可以 show 一下那个 CD 影像吗 ？Professor Sina would like to see the CD scan. Okay, okay.
Okay. So less light. You need to decrease light. Because we have to start now.
Okay. May I ask Professor Seho? Professor Seho, can you listen?
Yes.
Okay. We understand your experience. By your experience for this case, maybe you don't need artificial prioration, right?
Artificial assistance?
Prioration.
Prioration.
Aside this, in this case.
Yes, it will be better if we were able to do that. The concern here is that we try to do that, but this patient has a history of surgery, liver resection. That means that peritoneum cavity is not now free, is not available. It was impossible to inflate and to separate diaphragm from the liver, even by injecting about 300 cc. And I decided to stop the peritoneum filling because there was no chance to obtain a clear separation between diaphragm and liver. Now, according to touch technique, you can see on the draw that the free probe will be inserted at distance from the diaphragm. That means that we will try to limit the damage to the diaphragm. But this is, in this case, I think even by using multipolar radiofrequency ablation and no-touch technique, this risk remains. But we will limit it.
Okay, you mean the better window during the procedure. Okay, so now the needle, the probe has been inserted or not yet?
Not
Not
yet.
yet.
Oh, not yet. Okay.
We are waiting you.
We are waiting for the CT scan. Because I think many audience would like to see the CT scan. The tumor is how many distance away from the diaphragm?
Yes, okay. Okay, so we will answer the first one. So with multipolar radiofrequency the rule is always to insert the most difficult electrode first and finish by the easier one. Why? Because when we insert first and after the second and after the three one, the windows to perform US guidance decrease. So you have always, this is mandatory to start with the most difficult electrode first, because after that, more you insert electrode and difficulties to have enough room to use the ultrasound during the procedure.
Is any different opinion by operator? If you handle this case, did you have any?
The diaphragm is okay during the procedure.
Without artificial prioritization ascites, you mean?
No.
Okay.
We don't use artificial ascites, but the tumor is very close to diaphragm, so you need the thoracic approach.
So I will insert
And
the
during
first
the
one
procedure,
at
I wonder if
the
there is
inner and upper side of the nodule.
So you don't need ultrasound guide.
No, we need it, of course.
By a free hand.
Okay. I don't know if you are able to see the needle. The needle is here. Here, in the shadows of the rim. You see that? The point? I'm moving the electrode, but the target is not here, so I will adjust the course. Okay. Okay, you see the needle? Okay, so that's exactly what I want to do. Okay, I go behind the lesion because the stake here is to get margin. So we are to get margin behind the tumor and front of the tumor. So